housekeeping slides here. So for pharmacy colleagues who might be on the line, this is actually an accredited program. So please keep this in mind. Next slide. Standard disclaimer here. Next slide. And here are the disclosures for myself as the moderator. And on the next slide, we have disclosures for Dr. Savard. This is a program that was developed by a committee consisting of myself and as well Dr. Glenn Myers, who's a clinical pharmacist in New Brunswick. Next slide. And these are the program objectives. So first is to describe the prevalence of brain metastasis in patients undergoing therapy for HER2 positive metastatic breast cancer. The second is to review guidelines for management of brain metastases. And then the third is to review clinical trials evaluating efficacy and safety of antibody drug conjugates for treatment of patients with HER2 positive breast cancer and brain metastasis. So with that, I'm going to hand over to Dr. Savard. Oh, and before you start, I just wanted to mention we do have opportunities to ask questions, okay? So you can put questions in the chat. There'll be an opportunity to raise your hand, but we're going to save questions until the end of the presentation. Okay, now you can go ahead. Thanks, Dr. Savard.
Thank you so much, Dr. Jerzak, for inviting me to present today on brain metastasis. And hello, everyone. Bon appétit for those who are eating. So before we start off, a quick review of the terminology used in this presentation. There are two clinical categories of brain metastasis. The stable ones are brain mets treated with local modalities and non-progressive, and the active ones are either untreated asymptomatic or treated with local modalities but progressive. Historically, in most clinical trials, stable brain mets were allowed and active brain mets were excluded. Breast cancer has the second highest incidence of brain metastasis among all cancers. The risk and incidence of brain mets varies depending upon breast cancer subtype. On this bar chart, you can see that the HER2 positive estrogen receptor negative has the highest incidence, followed by the triple negative and the HER2 positive estrogen receptor positive, and finally HER2 estrogen receptor positive, HER2 negative. Furthermore, it is important to note that the brain is frequently the first site of relapse in patients with HER2 positive metastatic breast cancer. In this recent population-based cohort study led by Dr. Jerzak, similar trends are reported for our population in Ontario. In this study, 1 in 7 or 14% of women in Ontario diagnosed with de novo metastatic breast cancer between 2009 and 2018 received radiation therapy for brain mets after a median follow-up of 19.3 months. In the treatment context of this study period, the radiation therapy to brain was an excellent surrogate for incidence of brain mets because the mainstay of therapy for these patients remained local at that time. These line graphs show the cumulative incidence of brain mets identified by treatment with radiation therapy to brain and cumulative incidence of that in the HER2 positive hormone receptor negative and HER2 positive hormone receptor negative population. You can see that very few patients had brain mets at the time of metastatic breast cancer diagnosis and that the numbers increase with time. The cumulative incidence of brain metastasis was higher among patients with HER2 positive hormone receptor negative at 35%, and then HER2 positive hormone receptor positive at 29%, and triple negative breast cancer at 22%, compared to those with hormone receptor positive HER2 negative at 12.1%. Importantly, the marked differences in the incidence of brain metastasis and time to development of brain metastasis based on breast cancer subtypes highlights intrinsic difference in the disease biology of the breast cancer subtypes and their propensity to metastasize to brain. Another study was presented in 2023 at the San Antonio Breast Cancer Symposium regarding brain metastasis prevalence per line of treatment and cumulative incidence in cohort of 18,000 real-world patients. They found a higher prevalence of brain metastasis at the initial diagnosis in that study compared to Dr. Jerzak's study. And this may be because of a more frequent routine imaging of the brain in the US or a more comprehensive database that captures brain metastasis irrespective of treatment with radiation therapy. In the first-line setting, the prevalence of brain metastasis was 11.2% and 6.3% for HER2 positive hormone receptor negative and HER2 positive hormone receptor positive, respectively. And these numbers increased to 36.9% and 26.5% at 5+ lines of therapy. As you can see in this table, brain metastases were also most common in patients with HER2 positive or triple negative compared to hormone receptor positive, HER2 negative, or hormone receptor positive, HER2 low subtypes for all lines of therapy. HER2 low status did not seem to influence much the cumulative incidence of brain mets for either triple negative or hormone receptor positive breast cancer subtypes. This data could have important implications for potential future brain metastasis screening program. Currently, there is a lack of evidence that routine CNS screening helps patients live longer or better lives. Therefore, it is not recommended in the main guidelines, such as ASCO and ESMO. And this is because there are potential screening risks, including anxiety and detriment to quality of life, unnecessary treatment, and associated toxicities. The high cost for our system and limited resources is another con. The cost of an MRI done every 6 months will be $3,000 per year per patient. However, in the light of high cumulative incidence of brain metastasis, patients with HER2 positive metastatic breast cancer may be ideal candidates for brain metastasis screening. This is particularly true now in the setting of newer systemic therapies that have CNS efficacy and survival benefits. The screening could allow personalized care, patient care, and tailored systemic therapy approaches, with systemic therapies known to be effective in treating brain mets. The earlier detection of brain metastasis could also offer more targeted local regional therapy options and prevent or delay the use of all brain radiation therapy that is associated with high morbidity for our patients. Thus, in this treatment context, brain metastatic screening can impact treatment type, timing of treatment, and toxicity. In the latest ESMO guidelines on treatment of HER2 positive metastatic breast cancer for second-line setting, the treatment strategy changed based on the presence of active brain metastasis versus stable, no or unknown brain metastasis. For me, this really highlights the importance of tailoring the treatment strategy based on the presence of brain metastasis and the potential need of screening for brain metastasis patients with HER2 positive metastatic breast cancer. As per these guidelines, if the brain metastasis status is unknown, or if there is no brain mets or stable brain mets, trastuzumab deruxtecan is the recommended treatment in the second-line setting. However, in the presence of active brain mets, where immediate local intervention is not indicated, the combination of tucatinib, capecitabine, and trastuzumab is preferred over T-DXd. However, these guidelines might change in the near future based on recent data on the intracranial efficacy of T-DXd that I will present later. The latest ASCO guidelines published in 2022 are similar to the ESMO's. Also, they state that the data are insufficient to recommend for or against performing routine MRIs to screen for brain metastasis, and that clinicians should have a low threshold for MRI of the brain due to high incidence of brain metastasis among patients with HER2 positive advanced breast cancer. Here are a list of systemic therapies with some intracranial activity to treat active brain mets. It is important to note that the quality of evidence supporting these drugs is very variable, and they are listed from the most to the least evidence and based on their approval status in Canada. In this table, you will find a summary of the CNS PFS and CNS overall survival of the anti-HER2 targeted therapy based on randomized controlled trials. This does not include the data from Destiny Breast 12 that I will be presented at the end of this session. Based on the HER2 TLIME data, the combination of tucatinib, capecitabine, and trastuzumab yields a 13.9 and a 9.6 month CNS PFS for stable and active brain metastases, respectively. A survival benefit is also demonstrated in this trial. It is important to remember that in HER2 TLIME, 50% of patients had brain metastases, of which 60% had active brain mets, either progressive or untreated. Therefore, this combination has the highest quality of evidence for the treatment of brain metastases in this table. The CNS PFS for patients treated with T-DXd is of 12.3 months and 18.5 months for stable and active brain metastases, respectively, based on the pool analysis of 3 Destiny Breast trials. I would caution that in these trials, a small number of patients has brain mets and an even smaller number of patients has an active brain mets. We will take a closer look at this data in the next slide. In the pool analysis of Destiny Breast 01, 02, and 03, a total of 148 patients with brain mets at baseline treated with T-DXd were included from 3 trials, and a total of 83 patients with brain mets treated in the comparator arms were included. Some of the endpoints of this pool analysis were intracranial objective response rate, intracranial duration of response, and CNS PFS. Of the 148 patients with brain mets at baseline who received T-DXd, 104 had stable brain metastases and 44 had active brain metastases. The objective response rate were 45% for patients with stable and active brain mets treated with T-DXd, compared to 28% and 12% in the comparator arms. The median intracranial duration of response were 12 and 18 months for patients treated with T-DXd with stable and active brain mets, respectively. In the comparator arm, it was 11 months for the ones with stable brain mets and could not be calculated in the group with active brain mets. For all patients in the T-DXd or comparator pools, with or without brain mets, the first progression site was in majority extracranial only. When comparing patients with or without brain mets treated with T-DXd pool, similar rates of grade 3 adverse events, dose reduction, and discontinuation were observed. However, these rates were lower in comparator pools. Based on this, we can conclude that T-DXd exhibit possible robust intracranial responses in patients with treated and notably untreated brain mets. The Tuxedo-1 study was specifically designed to address the critical question of whether T-DXd is effective in treating brain metastases in patients with HER2-positive metastatic breast cancer. At the time, it was considered a bold and innovative trial as it enrolled patients with either newly diagnosed untreated brain metastases or those with progression after prior local therapy. Notably, all participants had brain mets that did not require immediate local treatment. The primary endpoint was objective response rate in the central nervous system, CNS, using the Raynaud criteria. In addition, the study evaluated several key clinical outcomes, including clinical benefit rate, progression-free survival, and overall survival. A total of 15 patients were enrolled in the study, and 14 of them received T-DXd. Let's take a look at their baseline characteristic. About 40% of participants present with neurological symptoms, and 2/3 had de novo metastatic disease at the time of their initial diagnosis. Now, if you focus on the right-hand side of the slide, you'll see the breakdown of prior HER2-directed therapy. All patients had been treated with both trastuzumab and pertuzumab. 60% had received T-DM1, and roughly a quarter had been treated with lapatinib. Finally, at the bottom, you will notice that the median number of prior lines of therapy for metastatic breast cancer was 2, with a range spanning from 1 to 5. Here are the primary results for the Tuxedo-1 study. As shown on the waterfall plot, 2 patients achieved a complete response, and 9 had a partial response, leading to a remarkable CNS objective response rate of 73%. On the right hand side, the Kaplan-Meier curve show a median progression-free survival of 14 months. To conclude, the Tuxedo-1 result are highly encouraging, particularly giving the robust intracranial responses. Although not shown on this slide, Dr. Sura and colleagues also reported on patient-reported outcome, including global health status. Importantly, patient maintained stable physical, emotional, and cognitive functioning throughout the study. Given the encouraging results of TDXD in patients with active brain metastases, it naturally raised the question among clinicians and researchers, could TDXD also be effective in treating leptomeningeal disease? As you know, leptomeningeal disease is a particularly aggressive and devastating form of CNS involvement, characterized by metastatic spread along the lining of the brain and spinal cord. Its incidence is rising, especially in patients with HER2-positive breast cancer, as improved systemic therapies are allowing patients to live longer, long enough to develop brain mets, and subsequently complications like leptomeningeal spread. Historically, the prognosis of leptomeningeal disease has been extremely poor, with overall survival typically ranging from just a few weeks to approximately 4.5 months. This underscored the urgent need for more effective treatment in this space. The DEBRA trial aimed to address this important clinical unmet need through a dedicated exploratory signal-seeking study. It includes 5 distinct cohorts of patients with metastatic breast cancer and brain involvement, all treated with TDXD. Cohort 1 include 8 patients with HER2-positive breast cancer and stable brain mets following local therapy. Cohort 2 focused on patients with either HER2-positive, HER2-low disease who had symptomatic untreated brain mets. Cohort 3 and 4 enroll patients HER2-low and HER2-positive, respectively, with brain mets that are progressing after local therapy. Most relevant to our discussion, cohort 5 include patients with leptomeningeal disease, either HER2-positive or HER2-low. There were 7 patients in this cohort, making it one of the few prospective evaluation of TDXD in this particularly challenging population. Let's first look at the result of cohort 2 and 3, which include patients with either HER2-positive or HER2-low breast cancer and active brain mets. What's interesting and I think quite reassuring is that some of the encouraging signals observed in Tuxedo-1 trial are also emerging in the DEBRA study. That said, the objective response rate in these cohorts were slightly lower, 46%, but still suggests meaningful intracranial activity of TDXD in this population. Let's now focus on cohort 5, which is of particular interest. This cohort included 7 patients with leptomeningeal disease, either HER2-positive or HER2-low. Here you can see the Kaplan-Meier curve for progression-free survival. In this small but important group, the median progression-free survival was 8.9 months, a very promising signal in a setting where outcome, as I said before, have been historically extremely poor. Now turning to overall survival, shown on the left-hand side on the slide. So the median overall survival in cohort 5 was 13.3 months over a year. This stands in stark contrast to historical data, again, where median overall survival for leptomeningeal disease was typically ranged for, as I said before, a few weeks to 4.5 months. Of course, we have to acknowledge the small sample size, but the findings are nonetheless, I think, very encouraging. On the right side, you'll see the breakdown of responses by HER2 and hormone receptor status. What's notable is that we see a persistent clinical benefit even among HER2-low patients and regardless of their hormone receptor status. Importantly, the median overall survival was consistent high across a subgroup, which is reassuring and suggests a potential broad benefit in this population. So these are the key conclusion and clinical takeaway for this part. So I'll just skip this. So the question of how TDXD performs in patients with active brain mets and leptomeningeal disease was also explored in Rosette brain metastasis study. While it has not received as much attention, it remains a very important piece of evidence. Rosette was a large, multi-center retrospective chart review conducted in Japan. It included patients with HER2-positive breast cancer and brain metastases, ranging from stable disease after local treatment to untreated brain metastases, and even symptomatic cases. So to identify eligible patients, a questionnaire was distributed to all 344 medical institutions in Japan to collect data on real-world use of TDXD for HER2-positive brain metastases. Notably, patients treated with TDXD as part of clinical trial were excluded, making this a truly real-world cohort. The study allowed investigators to assess key real-world outcomes, including progression-free survival, overall survival, time to treatment failure. Ultimately, 62 institutions reported eligible patients and agreed to participate. Here are the results of the Rosette study. It includes, as I said, an heterogeneous population, patients with stable disease, active brain mets, even some with leptomeningeal disease. So when looking at the entire cohort, the median progression-free survival shown on the left was 6.1 months. The overall survival was not reached yet. And on the right, the median time to treatment failure was approximately 10 months. So what happened if we break this down by specific patient subgroups? So on the left, you see progression-free survival, and on the right, overall survival, each stratified by type of CNS involvement. So what's striking to me is that the patients with leptomeningeal disease in green appear to fare just as well as those with active brain metastases. Both progression-free survival and overall survival in this group were not only much better than what we have seen historically. So this finding suggests that TDXD really, again, offer meaningful disease control in the most challenging CNS setting. And perhaps, most intriguingly, this raises the possibility that in select case, local therapy for brain metastasis might be safely deferred. So after multidisciplinary discussions, we may consider deferring local therapy in selected patients. So we do need to be cautious when using radiation therapy around the time patients are receiving antibody-drug conjugates. This concern was brought into focus by the study published in the JAMA Oncology 2023, which raised awareness about the risk of radiation necrosis when ADCs, specifically either TDXD or sacituzumab govitecan, are administered concurrently with radiation therapy. So the study defined concurrent radiation as treatment given within 7 days before or 21 days after ADC administration. Looking at this data, the cumulative incidence of symptomatic radiation necrosis was notably higher in patients who received ADC concurrently with the radiation compared to those treated sequentially. While the overall risk remained relatively low, it can be as high as 1/3 of patients when proper spacing isn't observed. So while ADC are highly effective, we need to be very mindful of this interaction and coordinate closely across disciplines to minimize risk. At ESMO 2024, the phase 3b/4 DESTINY-Breast12 study was presented. So this is a large, non-comparative trial evaluating the efficacy and safety of TDXD in patients with HER2-positive metastatic breast cancer, specifically focusing on 2 cohorts, those with and without baseline brain metastasis. The study enrolled 263 patients in the brain metastasis cohort and 241 patients in the non-brain metastasis cohort. To our knowledge, DESTINY-Breast12 is the largest, or at least one of the largest, prospective study of TDXD in patients with HER2-positive disease and either previously treated stable or active brain mets. So these are the baseline characteristics of patients in DESTINY-Breast12. So patients with brain metastasis at baseline are shown on the left in dark blue, while those without are shown on the right in turquoise. Overall, the two groups were well balanced. At the top, highlighted in red, you can see the median number of prior lines of therapy. Most patients had received 1 or 2 lines. In the center of the slide, it's evident that nearly all patients had previously been treated with trastuzumab and pertuzumab, and about 40% in both groups had received TDM1. At the bottom, take note of the time from last radiation therapy to TDXD initiation. There was a relative long interval between prior brain-directed RT and the start of TDXD, which is important consideration when interpreting the CNS safety and efficacy outcome. So these are the progression-free survival results for patients with baseline brain metastasis. So the 12 months PFS rate was 61.6%, which is quite encouraging. What's particularly interesting is the breakdown at the bottom, looking specifically at the patients with active brain mets. This includes both untreated lesions and those previously treated with, but now progressing. Both subgroups show clear benefit from TDXD, suggesting activity regardless of prior local therapy status. Looking at CNS-specific progression-free survival, the 12-month rate was 59%. If you focus on the chart below, you'll see two groups differentiated by color, green for patients with stable brain mets and blue for those with active brain mets. Interestingly, both groups show very similar outcome with roughly 60% CNS-specific progression-free survival at 12 months. When we look at the objective response rate, you can see it illustrated clearly in the waterfall plot. So what I found particularly encouraging is that nearly all patients experience either stable brain metastasis or some degree of tumor shrinkage. Even if it's not a formal objective response by RECIST criteria, this outcome is very promising. From my perspective, I don't always need to see a huge shrinkage in the brain metastasis to feel confident about the treatment. When opting for systemic therapy in the metastatic setting, especially if the patients are asymptomatic, the key factor is that the brain metastases are not progressing. As long as the lesion remains stable, I consider that like a really positive results. The overall survival results really drew a lot of attention. So what's striking here is that patients with baseline brain metastasis shown on the left and those without brain metastasis on the right had nearly identical 1-year overall survival rates, both around 90%. This is especially noteworthy because historically the presence of brain metastasis has been associated with worse prognosis, as I said multiple times before. But the narrative is clearly shifting. So for patients with HER2 positive disease, even with brain metastasis, there's some potential for long-term, survival. So seeing 90% of patients alive at 1 year is very good and encouraging. So with all the data we reviewed, it's clear we have made meaningful strides over the past 3, 4 years, 5 years in treating brain metastases in HER2 positive breast cancer. Still, several important questions remain, particularly in the metastatic setting involving the CNS. So one major question is whether antibiotic drug conjugate can be used earlier in the treatment course to help prevent the onset of brain metastasis. So I'm eager to see the full result of the CBREST-09 regarding this. So this trial is evaluating TDXD in the first-line setting, and it may help address that very important question. The interim results of this trial presented at ASCO this year show that the TDXD combined with pertuzumab achieve a statistically significant progression-free survival benefit over Cleopatra regimen, and this is across all subgroups. However, I didn't see any CNS-specific progression data. I don't think it has been reported yet. Similarly, the HER2 trial is assessing the role of maintenance tucatinib in the first-line setting. So the results of this study will also be critical in guiding our approach to CNS prevention. Another area of interest is whether we can enhance efficacy by combining targeted therapies such as dual drug ADC, Again, the full result of DESTINY-Breast09 may offer some more insights on this. And of course, several long-standing clinical questions also remain top of mind. So how should we manage patients with brain-only metastatic disease? And what is the optimal approach for patients with isolated CNS progression but stable extracranial disease? Thank you. I think, yeah.
Okay, great. Thank you so much, Dr. Savard, for going over the data so comprehensively. I think maybe what we'll do is why don't we take a quick pause for any questions, and then after that we can go over the cases. So, I mean, if anyone wants to unmute or raise their hand, please feel free to do so or put your question in the chat. Alternatively, if nobody has any burning questions, we will let people think a little bit about what they want to ask and move forward with the case, if that's okay with you.
Yeah.
Why don't we do that then, because I don't see any hands up right now. So how do you want to do? Would you like me to read the case, or would you like to read the case?
I think you can read
it. Okay,
so.
I can do it. Yeah, no problem, no problem. So this is a 57-year-old postmenopausal woman with HER2 positive breast cancer. Initially had an early stage left-sided disease that had a low ER expression, PR negative status. And clinical staging at diagnosis was clinical T2 and 1 disease, treated with neoadjuvant therapy, anthracycline-sparing approach, which is appropriate, carboplatin, docetaxel, and trastuzumab times 6. Unfortunately, she did have a fair burden of residual disease post-operatively, PT1 and 1 microscopic disease. And then went on to complete trastuzumab. This was at a time before Kadcyla was routinely available. Unfortunately, not so long after completing the trastuzumab therapy, about a year and a half afterwards, she was found to have pulmonary nodules. And biopsy was done confirming HER2 positive metastatic relapse. So at that point, she received standard of care weekly Taxol, trastuzumab, and pertuzumab, and then ongoing trastuzumab, pertuzumab maintenance. Unfortunately, she did really well for a long time, up until cycle 34 of pertuzumab, but trastuzumab, which is not uncommonly seen. But at that point, she had some nonspecific neurologic symptoms, and imaging of the brain with CT, it just so happens in this instance, showed a small 1.5 centimeter lesion in the frontal lobe, suggestive of brain mets, and this was confirmed on an MRI. The patient herself, relatively healthy. I mean, type 2 diabetes, hypertension, reflux, some anxiety. You could see her list of medications there. We can go to the next slide.
I think...
or is that it?
Oh, no, there's one other
yeah.
question.
Yeah. So, I mean, I think that this question here was just intended to get a sense of what people are doing when it comes to brain imaging. This remains a topic of, of interest without clear international guidelines, as you had mentioned, Marie-France. So there's some mixed recommendations in the guidelines. I mean, so I'm curious what people do. We have participants not only from Sunnybrook. I think our practice even within Sunnybrook's is a little bit mixed, but people are doing at other centers. Does anyone want to comment about their practice for routine screening for brain metastasis? I don't want to pick on anybody. Do you want to start off maybe, Marie-France, by letting us know what you do in Ottawa?
Yeah, so, well, in Ottawa, we don't routinely screen, but we have a very low threshold to screen patient. And more for a selected case, I do tend to order, let's say, when they present metastatic, a baseline MRI to maybe identify asymptomatic disease, to try to prevent some morbidity, especially in patients that have, I would say, very high burden of disease. They present with like a lot of visceral disease and stuff like that. For sure, we look for this CNS symptoms, and as like even for symptoms, like a mild headache or, like sometimes it's borderline symptoms, I will have a very, very low threshold to do MRI of the brain, preferably. Usually I try maybe every year or so. Yeah, on there.
Right. I mean, I think, yeah, for me personally, I used to not screen at all because we were doing the brain met screening trial pilot feasibility study of screening versus not for patients with HER2 positive metastatic disease or triple negative. We actually finished that study, and we'll hopefully the abstract will be accepted. We submitted to Society of Neuro-Oncology toward the end of the year. But I mean, I think given the changing landscape of systemic therapy for HER2 positive disease, I find myself now doing screening in select scenarios. So for example, when patients have progressive disease extracranially, I am looking at the brain as well. I think it's just important to know. So for example, if you're starting second line TDXD, it's important to know what the status is in the brain. Let's say incidentally, a couple months later, you find a brain met, it'd be important to know, was that there before, is that brain lesion resistant to TDXD or not? And same thing in the third line setting. So I don't think there's a right or wrong answer. I think, practices are still quite varied, not only within centers in Canada, but also internationally on this topic for the reasons that you outlined in the presentation. So, I mean, I think the next question we can probably go to is, what is a practical approach to choosing treatments in patients with treated versus non-treated brain metastasis in the HER2 positive metastatic breast cancer setting? So this is, I think, a good question. It's another example of how quickly things are changing in medical oncology for breast cancer. You've shown some compelling data suggesting that tucatinib-based therapy and TDXD works in patients with brain mets, even if they have not received prior local therapy. So do you have any tips or tricks, Marie-France, in what scenarios, you may consider sparing local therapy?
Well, if it will depend, and we touch a bit on that, like the type of intracranial involvement, the size of the lesions, the number of lesions, how quick they developed, the location, if patient is at risk of becoming rapidly symptomatic, or if the patient is already extremely symptomatic. So all of these, factor, we took into account when deciding about, should we give a change line of systemic treatment? And I'm talking obviously about systemic treatment that can have a brain, have some efficacy in the brain, such as TDXD or tucatinib. So it will depend also in where the patient is in their sequences of treatment. Do they already receive those treatments or not, right? So it will depend of all these factors. But I would say that let's say if there's a few small, not symptomatic lesions, in new lesions in the brain, I will tend to give them a treatment like TDXD or tucatinib, a treatment that has some intracranial efficacy.
Right. Yeah. Same here. And I think, it's important to emphasize it really is a multidisciplinary discussion and decision. So having your radiation oncology colleagues and neurosurgery colleagues on board is important. In some cases, it's a no-brainer, no pun intended, I guess. But if there's a only option for local therapy, let's say is whole brain, because the patient has a lot of small lesions, many small lesions, you really want to try to spare the toxicity of that approach. But I rarely make these, actually, I don't make those decisions in isolation, as I'm sure, you guys as well in Ottawa do multidisciplinary case discussions. And I'm curious how that works locally and in your center. Do the CNS radoncs attend your breast MCCs?
Yes, a lot of them, they also are breast radon, so they will attend
Okay.
the MCC. We just discussed a recent case at the MCC, a patient she was on first line maintenance with trastuzumab, pertuzumab, and she had a local, recurrence. Anyway, I don't want to disclose all the cases, but yeah, so we did discuss, and also the risk of retreating with radiation therapy is taken into account as well. So as you mentioned, it's extremely key to have the radiation oncology input and to take the decision in group, right? And also trying to foresee what will be the next course if I do that versus if I don't do that, and like to make sure we give the patient the best options also in the future. Yeah.
Right. And it's sometimes important to link in the patient as well. So if it's not clear what decision is best, to incorporate patient preferences
Mm-hmm.
as well. Any comments on that? Additional thoughts from the group? Okay. Maybe so we do have some time to go through our next case. Do you want to go over that?
Yes.
And this is a relatively quick case. 56-year-old university professor with metastatic HER2 positive breast cancer, this time strongly ER and PR positive disease. Again, presented with a early stage disease, but more advanced clinical T3 and 1. And during the staging process, unfortunately, was found to have innumerable liver metastases, as well as some elevation in AST and ALT. So she was treated, this was a few years ago, with standard of care first-line therapy, weekly paclitaxel, trastuzumab, pertuzumab, followed by maintenance, trastuzumab, pertuzumab, and endocrine therapy. And similar, you had mentioned, Marie-France, any sort of even subtle neurologic symptoms, you want to make sure we're looking at an MRI. So she had reported some white noise, maybe not so subtle migraine visual aura, and an MR was done showing 3 foci of suspicious for brain metastasis, the largest measuring about 3 millimeter. And on repeat MRI, it looks like in total there were five lesions. She was referred to a tertiary care center. It sounds like a decision wasn't really made at her local hospital in terms of treatment. And by the time she got there, a repeat MRI showed 10 lesions, and trial of Dex didn't change her symptoms. So what do you want to go to the next slide there? Right. I think we already discussed the MCC
Yeah.
component there, but in this case, so it's different than the other one. So the first patient had just a single solitary brain met, asymptomatic, but in this case, she has 10 brain mets. They are symptomatic. Symptoms are not improving despite Dex. What would you do in this case, Marie-France?
Yeah, and also I think the important component is the how quick those metastases are developing over time, right? Just in
Absolutely.
between like a few weeks MRIs. So in this situation, I think we need to have a treatment that will cover all, the CNS, unfortunately, right? So either, I would, even if there's no extra, I don't think there's extra cranial progression in this case. So even if there's no extra cranial progression, this is a situation where we can consider, I think, switching for something that can penetrate the blood-brain barrier, a medication, or maybe all brain metastasis, right? I mean, for sure, 10, we can technically do radiation therapy to the 10 lesions, but in this particular case, I'm curious to see what is your opinion, but it may, she may develop 2 months later more, lesions, right?
Yeah, I completely agree with you. This is a case where I would use TDXD second line.
Mm,
Just try to get a more systemic approach to treating
yeah,
the brain and keeping the radiation as a backup option. After reviewing, of course, with our radiation colleagues, but it seems
yeah,
like radiation was felt, if required, would have been a whole brain type
yeah.
of approach. Do we have any radiation oncology colleagues on the line who want to comment on this? I think I saw Hanbo, who also does CNS and breast, but he might have come off the call at this point. The other question is, now we've seen at ASCO DB09 results with first-line TDXD. As you said, we didn't see any data in terms of time to CNS progression or time to development of CNS disease. But it'll be really interesting, to wait and to see that data. It's possible that by using frontline TDXD in certain cases, not yet approved, of course, but we might change the natural history of the course of HER2 positive breast cancer, and maybe, who knows, maybe we'll see a lower incidence of brain mets.
Yeah,
But
I
the
think
data
this
is pending.
It's a very exciting question relating to this trial.
Yeah. And then the other one is, that we're waiting for too, is the HER2 CLIMB-05 data, which we haven't seen. I think probably waited toward the end of this year with the maintenance tucatinib in the first line setting. But yeah, definitely will be interesting to see both in the first line setting with CNS active therapies, whether the incidence of brain mets might go down. Do you want to maybe go back to the second slide? I don't know if I missed any questions there. No. So what would you offer this patient? So that brings us to the end, I guess, of the structured component of the talk. Maybe I'll open it up again to any questions. You can please feel free to raise your hand, or if you're shy to do that, please feel free to use the chat and we can have your questions answered.
We have a quiet group today.
Yeah, it was very good attendance. I think you covered the data so nicely.
I think it was, there was a lot of details, Kesha, when you planned this program. So
okay, well, okay, perfect. So we have, thank you, Dr. Liu, for the question. So the question is, so Dr. Liu is pathologist lead of the breast pathology program at Sunnybrook. And the question is, do they retest HER2 in the trials? So I don't know if you want to comment on that, Marie-France, but also, in the trials and what you do at your center. So I think the question is relating, so if patients have HER2 positive locally advanced disease and then post-operatively in the residual disease, do you routinely retest HER2? And then what about at the time of metastatic progression? What do you do?
Yeah, no, so we don't retest HER2 routine in our trial. Like say if they receive neoadjuvant treatment, then they go for surgery. And they were initially HER2 positive because in fact I don't think it's good. Well, we kind of don't want to know if it's now HER2 negative, right? Because it will, then we'll ask ourselves, should we keep treating with HER2 targeted treatment? They did with TDM1, there was in the Catherine trial, there is data about that where they look at if the HER2 status change after neoadjuvant chemotherapy, and do they still benefit from TDM1? And in fact, even the one that has switched, it seems that they were still benefiting with, from TDM1. So, and based on that, even when sometimes it's tested for other reasons, the HER2 status, and then we present the case at the rounds because we are not 100% sure what to do. Should we, if there's residual disease, should we switch to TDM1 or not, and if it's HER2 negative. And usually, in our rounds, we're still recommended to keep going with the standard approach. I don't know if you have other data that you can quote or another approach, but
yeah, I mean, like you said in the Catherine data, even if the residual disease was HER2 negative, those patients still seem to benefit. I think maybe Dr. Liu, if you want to comment, but I think that in terms of how we do it at Sunnybrook, in terms of the HER2 status retesting, I think it's just the morphology looks different. Is that right?
So yeah, if it's post-neoadjuvant, but post-neoadjuvant it was HER2 positive before neoadjuvant chemo, we do not retest. But on the metastatic setting, we usually repeat the ER, PR, HER2, all three of them. So on metastasis, we will repeat. But on the excision specimen post-neoadjuvant,
Yeah.
we will not if it's HER2 positive. HER2 negative, we always repeat post-neoadjuvant as well. But anyway, in the metastatic setting, we just retest regardless of regardless of the ERP HER2 status on the primary site.
Yeah.
And then so I wasn't sure because sorry, I'm a pathologist, so I can only ask pathologists. I can only think of pathology.
That's a good
Your
question.
presentation was very clear, yeah. But yeah, so that was always the struggle. And then also now, and HER2 is sort of funded for like the HER2 low, and now you're funded for HER2 positive. So we've gotten requests before, like where the clinician really want to give an HER2. So
Yeah.
that we will try to and then and then they ask us to retest, and let's say the test was like borderline, then really try to kind of make it HER2 negative, HER2 low, negative or like low, HER2 low, so that the patient can qualify for the drug, get funded.
Well, yeah, that's an excellent
all those
question.
kind of things, yeah.
Yeah, that's the thing too, right? So if it was initially positive and then you repeat the biopsy and it become negative, you can always ask yourself, well, is there some heterogeneity, are all the sites the same, is there still? So I don't know how frequent how frequent do you rebiopsy in the metastatic setting patient?
I think we generally do try to get a tissue sample when possible, just confirm that it's breast cancer recurrence
Yeah.
and the subtype, but sometimes it's just not possible as
No.
there's just small, disease that's not amenable to biopsy, or the location is challenging to biopsy, or it's just in
Patient
the
prefer
bone.
not to have
Right,
it,
right.
right?
It's just,
Because
exactly, it's challenging. But I think,
Yeah.
this topic was specifically about HER2, but the topic
Yeah.
of HER2 low comes up a lot. And often what we do is the first step is we ask our colleagues from pathology to have a look at any previous samples that are available in the lab already
Yeah.
to recheck with a second view. I mean,
Mhm.
in the olden days, it didn't really matter whether HER2 was 0 or 1+, it didn't make any treatment changes. So, but now going back with a view to specifically find HER2 low disease, we do sometimes see this,
Yeah.
that the reporting changes.
Yeah.
And if it's still HER2 0 and we're looking to try to get TDXD, then we may sometimes ask for another biopsy.
Yeah. So we do about the same in our institution. Yeah, I will say.
That was a great question.
Mm.
I think if there are no other questions, I don't see any hands up or anything new in the chat. You got a comment about your great presentation. I think we'll bring the session to a close. So thank you so much, Dr. Savard, for going through the content so thoroughly and so clearly, and for answering the questions and going through the cases together. It was a pleasure to have you join our rounds, and we look forward to having you back in the future.
Thank you so much for inviting me.
Bye. Thanks, everyone.
Take care. Bye.
And thank you so much as well for AstraZeneca for supporting the talk today.
Thank you.